Next, I'd like to invite Lucille Chalmers from Brisbane South Primary Health Network, and Louise is going to talk to us about contracting for outcomes in a primary health setting. Thank you.
Thanks, Chris, and good afternoon. It probably is now to everyone. I'd just like to start by acknowledging the traditional owners of the land on which we meet today, acknowledging elders past, present and emerging, and all those Aboriginal and Indigenous people in the room. So in the spirit of the sessions that we've had so far and the papers so far, very much at that system level, I sort of want to bring the helicopter right down and hover over a small area south of the city of Brisbane and talk to you about an example of a trial that we are implementing at the moment. And it came about really, I guess, because as commissioners, as a primary health network and as a commissioner, we are often asking ourselves where we can best invest the small dollars that we have for the maximum outcome. And indeed, how do we know if we, as a PHN and a commissioning body, is making a difference to the health of our community? So that's one sort of question that occupies our mind often. And I guess the other is an acknowledgement that the discipline or the learnings of commissioning in the healthcare context in Australia is new and still in that infancy, learning what's going to work from international examples in our space and what we need to adapt and do differently. And with outcomes-based commissioning and outcomes-based contracting as a way of implementing that, feeling like it was gaining a bit of a head of steam and a lot of interest, we were keen to understand how to implement the lessons that were being learnt internationally to the example of the Australian health landscape, but also the scale of the way that a PHN operates, which is relatively small when you look to other outcomes-based contracting examples, particularly in the NHS, which is where we often look. So we wanted to, I guess, contribute to the debate, contribute to the knowledge base, and undertake a trial that was going to allow us to test these sort of concepts in our world, understand what it meant for us as providers in a PHN and what it meant for the service providers that we work with and what impact might it have on the consumers. I'll get the hang of it. Okay. So we were attracted by this idea of using trialling a shadow contract. And what that was going to allow us to do was to go through a process of identifying those outputs and outcomes that we thought would make the biggest impact on our population, that we could then practically measure the outputs and outcomes, and really to get an understanding of how that worked, what the processes were and the impacts of tying payments to outcomes on a broad level, and to develop this shadow contract, which would allow us to do all of that in a fairly low-risk environment. And really what we were looking to do was to use the process to inform the way we were commissioning, and, as I said, to contribute to the debate a little bit more broadly. I wonder if there we go. So the way we went about doing that was approaching two of our existing service providers in the drug and alcohol area, and we essentially said to them, we want to trial this new way of doing things. Would you like to be part of that process? So from the outset, this has always been a partnership approach. We recognised that while we were learning as service providers how this might work, we had to absolutely have it fully informed by the impact it was likely to have on the service providers. And so this has very much been a joint approach all the way through. So the idea of this shadow contract is that we legally contract these service providers in the same way that we always have, which is essentially an activity-based contract. But we have developed a contract that sits under that, and we track under that to see what happens when we pay, if we'd paid on outcomes in real life. So we can actually compare the two. And by doing that, we get the information that we need to a certain extent. It's still an artificial level trial. However, it de-risks it. And we felt that we needed to do that in these circumstances. So we came together over a 6+ month period. It actually took us longer than we imagined it might to develop this shadow contract together. And we've been implementing that now for 8 months, and we've got certainly some learnings so far, which I'll share with you. So we worked with a consultant with some specialist expertise in this space. This wasn't something that, while we had parts of the puzzle that we needed to develop a contract, we bought some extra expertise around that. And we developed collaboratively the agreed program logic model. So we worked with these two providers and us as the team from the PHN, and over quite a long period of time agreed what that program logic model would be, what the outputs and outcomes would be, and how those payment mechanisms would work, and the KPI collection. So what we were trying to do was to work off what the service providers were already doing. We were conscious of while they were kind of willing participants, mostly willing, sometimes not less so, understandably, we were conscious of a burden that we were placing on them in asking them to be part of this process with us. So we tried to build on what they had. Didn't always quite work out that way because of the nuts and bolts of actually measuring here. But I would say the gold in the process so far has probably been this process. So actually sitting down together, collectively agreeing the program logic, how things can be measured, why it might sound sensible to do it this way, but in practice it's actually going to work better if we do it that way. That has been an absolute finding for all of us, I think, and had we stopped there, I still would have felt that there was value in the process, but I'm pleased we're still going to continue and to see what else we can find out. This gives you an example of the type of payment mechanism that we had in place. In fact, there's been some changes now that we've actually implemented this. We've found out there've been a few issues with it. The takeaway here, I guess, is just to have a look at the percentages we have in fact attached to payments. And you'll see that a very big chunk of, and this is the shadow contract, just to clarify, this is not what actually the providers will be paid for. But you'll see a big chunk really is still attached to the space that providers are pretty comfortable with. So input, as in, you sign the contract, you get your upfront payment. There's an activity base, which is really what is business as usual. And there are some output measures there that are pretty easy to measure and were very much in the comfort zone of the service providers. So that adds up to a very big chunk of your typical 100% contract. You'll also note that we have balanced the risk and reward. Lots of discussion about, is it a punitive approach, is it a reward approach in terms of bonus payment if outcomes are reached. So we've kind of balanced the two. There's a little bit of, it's a 95% payment if you don't reach the outcomes, but it's an 110% payment if you reach all of those outcomes. Again, recognising that while all of this is theoretical, the nature of this discussions all the way along really have been really quite genuine in terms of understanding what this would mean in practice. So there was a lot of discussion about what would happen if we were only going to get the 95%. Would our board allow us to employ the full range of staff, for example, or would we not be allowed to do that? So part of this is about collecting all of those concerns, and our ultimate evaluation report will make sure we reflect all of those, because that's the reality for service providers on the ground level. So, some of our findings so far. It's our first cut at doing the evaluation, and that process in itself has revealed a whole lot of issues we didn't anticipate, as is often the way with pilots. So we've had to do some adjusting on a few things, but just to pull out a couple of things that are worth sharing at this point. One is, I think, about the maturity, I guess, the sector is at, and it's not just AOD, but it's health more broadly, about actually finding the right outcome measure to reflect a real outcome for a client. So an example here was service provider 1. So the client scored well on intake in the outcome measures, but then saw a decline as a therapeutic intervention actually started addressing some of those issues. That's not unique to AOD. So I think it just raises that issue about something we all know. There's a reason why we're not doing outcomes better. It's because it's hard, it's complicated. And I think service provider 2 found that just because of the nature of the organisation that they are and at the point that they were getting referrals, they found that at the point of entry, The clients were tending to almost be on the road to recovery, so the size of their improvement wasn't as big as people thought, and the sensitivity around measuring that wasn't as easy as we thought. So both are still feeling like they're achieving outcomes with their clients, but they're not feeling like the outcome measures that we've chosen and we're tracking are reflecting that. Excuse me. So on the payment side of things, we've done the analysis about what would have happened had we paid on the results we've got so far. Service provider one would have had a small loss. That's about $7,000 out of a pot of about $150,000. The broader contract is bigger than that, but in terms of a percentage. So small loss, but probably not door closing time. Thank you. And the second provider would have had their baseline met, but no bonus payment. Okay. All right. So just some of the challenges that I want to share with you to date. A lot of it is that nitty-gritty kind of elements of implementing this sort of work at this small scale and as a pilot project. So we're learning, absolutely learning as we go along here. So some of it has been, as I said, the unexpected results from the baseline data. It's time consuming. This is all manualised. There's no system level processes supporting this at the moment because it's just that learning process. So that's, it's taking some time, but certainly learning as well. That agreeing of consistent data collection across service providers, we had hoped to be able to do this quite simply across the two. Hasn't worked out that way. They're different service providers. They see very different clients. They have different systems in place already. And as I said, one of our approaches was really about trying to make it as easy as possible for them. So we've had to live with those differences. I think just all the way along that reinforcing with service providers the purpose of outcomes-based contracting. So this is about us trying to understand if we shift a contract that focuses on outcomes, what does that mean? And that's really been one of our driving questions all along, is that if we have a contract that does measure outcomes, does that help get better outcomes in the end? And that's sort of one of the questions I think we're looking forward to having some more sort of idea about by the end of all of this. From the service provider perspective, there's some interesting responses to date. So that idea around collecting data interfering with the therapeutic relationship. And there's a couple of things I'll just sort of share with you, and I think that they're just a good sense of where people are at the moment in that need to collect data and that need to focus on outcomes. And I think that last dot point there about that concern that a focus on outcomes may become at the expense of clients. So I think, okay, that's definitely not the purpose. That is in fact the complete opposite of the purpose. So I just share that with you as a way of reminding us all that there's a long way to go in terms of there's a lot of change that needs to happen, I think, for people to be comfortable in the process of measuring change and being accountable for change and outcomes. Okay. A couple of other concerns that were raised is that issue around cherry picking, which many of you will be familiar with, that service providers will pick and keep the clients that they're going to get the best results and the potential payment. One of the big issues, I think, is this around we have chosen to do this at a small scale to service providers. Organisations work for multiple funding sources. If we're all doing it differently, that's going to overwhelm. Absolutely. Thank you. Okay. So just some of the benefits there. I think certainly from our perspective, I would say that learning to do program logics and implementing that entire process across all of our contracts, where our contracts now clearly state activity, outputs and outcomes. We don't have payments attached to them, but it's very clear what we're all aiming for. And jointly doing that work on the program logics has been a big win. From the service provider perspective, certainly doing this work has in fact focused them on collecting and measuring outcomes. I would argue that most not-for-profits, you can be fairly confident that they are already focused on outcomes, but they're now focused on measuring outcomes, and I think that's been a good outcome. Just to give you a sense of, if this is something you're thinking about, some of those factors to consider are around the size of the organisation, the ability of the organisation to wear some of that risk from a financial perspective, and just how ready that organisation might be. I'm conscious that I'm running out of time, but you'll be able to see the detail of that when you can access the slides afterwards. And I think just to make the point there that the closer someone is to those unfavourable circumstances, you invest less in the risk element. So the payment for the outcome should be a smaller percentage of their contract. I think what this has revealed for us really is the challenges of doing this at a program level versus an at-scale level. So whether that scale is perhaps a place-based approach where all organisations are working towards the same outcomes on, across sectors perhaps, or that scale is in fact all drug and alcohol across Queensland or the country. It's probably, there are multiple ways to cut the pie, but I think what we will be able to do in this process is identify what's from a people perspective, outcomes from a people perspective, but not from a population's perspective. So I think for me, this is just part of the journey that Australia is on in terms of how outcomes-based contracting and measuring outcomes and paying on outcomes can contribute to a value-based system. But there are some challenges at doing it at that smaller scale. I guess what I hope is this one particular piece of the puzzle will be matched with a lot of the other pieces that we're hearing about over these next 3 days, and ultimately we can get back up to that helicopter view so it is in fact meaningful and we're clear that where we as commissioners are investing is getting the best outcome for the communities that we work with. Thank you.